What happens when AI drops the word maybe from your medical record? Your doctor writes possible pneumonia in your chart. An AI system rewrites it as pneumonia. That one word changes everything: treatment decisions, insurance coverage, your understanding of what's actually happening. 2 papers this week tackle a question that cuts to the heart of clinical AI safety. Can these models preserve the uncertainty that keeps patients safe? Both point to the same uncomfortable answer, and it's worse than you'd expect. 2 papers, one uncomfortable thread. The first asks whether large language models preserve diagnostic uncertainty when they rewrite or summarize clinical text. The answer is no, less than half the time. The second asks whether adding uncertainty estimation as a safety net for medical visual question answering actually catches errors. It does not. It fails precisely where you need it most. Both papers ask the same fundamental question: what do we lose when AI smooths over the messy, uncertain reality of clinical medicine? The first paper, titled Possible or Definite, introduces something that should have existed already: a systematic benchmark for evaluating whether large language models preserve diagnostic uncertainty in clinical text. The researchers tested Claude Haiku, Gemini Flash, and a GPT model on 1,200 clinical text samples drawn from Mimic4 clinical notes and TCGA pathology reports. They set up 2 research questions. Can models preserve uncertainty indirectly when they rewrite or summarize clinical text? And can they directly identify and rank uncertainty levels when asked? The results are genuinely sobering. Under baseline conditions, the uncertainty retention rate, that's the percentage of times the model correctly preserves the original uncertainty level, dropped below 50% across all 3 models tested. Target retention rate was even worse, hitting as low as 33% for revision tasks, meaning the model frequently omitted the clinical target entirely. Now, the researchers did find that guarded prompts, instructions explicitly telling the model to preserve uncertainty, helped push retention up to around 63%. But that still means more than 1 in 3 uncertainty cues get lost. In clinical medicine, that gap matters. Clinical uncertainty is not a bug, it is a feature. Possible pneumonia and definite pneumonia trigger different treatment pathways, different monitoring intensity, different conversations with patients. When an AI model rewrites likely emphysema as just emphysema, it collapses a spectrum of clinical confidence into a binary that the original clinician never intended. And this does not just affect the immediate output. If a summary drops uncertainty language, every downstream system that reads that summary inherits the distortion. The uncertainty signal degrades silently through the pipeline. Now, I want to be honest about what this study does and does not show. The benchmark uses a specific 5-level uncertainty taxonomy. Real clinical text is messier than that. There is sarcasm, implicit hedging, institutional shorthand that models may handle differently. Only 3 models were tested, and the landscape is moving fast. Newer reasoning models may perform differently on these tasks. And critically, the study measures preservation of uncertainty, not clinical consequence. We do not yet know how often lost uncertainty cues actually change patient outcomes. That is the study we need next. If this kind of analysis is useful to you, the careful, honest breakdown that helps you separate signal from hype, take a second to like and subscribe. It genuinely helps more people find this content. Now let us look at the second paper, and it asks a question that should make every clinical AI team uncomfortable. The second paper comes from researchers at Amsterdam University Medical Center and the University of Amsterdam. It is titled Uncertainty is Not a Safety Net for Clinical VQA, and the title alone tells you where this is going. They benchmarked uncertainty estimation methods across 12 vision language models on clinical visual question answering. That is, answering medical questions about images like X-rays, CT scans, and endoscopy photos. They introduced a clever stress test called NOTA, which stands for none of the above, to see if uncertainty rises when the correct answer is deliberately removed from the options. The results reveal something that should reshape how we think about uncertainty in clinical AI. Label NLL, the simplest method, just checking the probability assigned to the model's chosen answer, turned out to be the best discriminator across nearly all 12 models tested. But here is the critical finding. Uncertainty estimation quality tracks model accuracy. Where models are strong, say, MRI interpretation at 69% accuracy, uncertainty is informative. Where models are weakest, endoscopy, histopathology, uncertainty estimation degrades. That is exactly backwards. You need the safety net most where the fall is hardest, and that is precisely where it breaks. The notice stress test is where things get really concerning. When researchers removed the correct answer from multiple choice options, models kept choosing confidently, and uncertainty scores did not rise to flag the error. In one striking example, a model's uncertainty actually dropped from 0.68 to 0.09 when it was forced to guess wrong on a chest X-ray. Think about what that means in practice. A clinician relying on uncertainty scores to know when to double-check would get no warning at the exact moment the model is most dangerous. The confidence signal is not just unhelpful, it is actively misleading. Now, some important caveats. The study tested post hoc uncertainty methods, approaches applied after the model generates an answer. Intrinsic uncertainty built into model training might behave differently, and that is worth exploring. The notice stress test is artificial. Real clinical errors are subtler. A model might pick a plausible but wrong diagnosis, not face a literal none of the above option. And the study focused specifically on visual question answering. Uncertainty estimation might perform differently in other clinical AI tasks: text generation, image segmentation, risk prediction. We should not overgeneralize, but the pattern is clear enough to take seriously. Both papers share a thread worth pulling on. The first shows that AI models strip away the uncertainty language that clinicians carefully embed in their notes. The second shows that the tools designed to detect uncertainty fail precisely when they matter most. Together, they paint a picture of clinical AI that is overconfident in its outputs and under-equipped to signal when it should not be trusted. The solution is not to abandon these tools. It is to build systems that treat uncertainty as a first-class clinical signal, not an afterthought. That is the design challenge for the next generation of clinical AI. Here is the question I want to leave you with. What should uncertainty-aware clinical AI actually look like? Should AI systems be required to flag when they are uncertain, the same way clinicians document their differential diagnosis? Is it enough to improve uncertainty estimation methods? Or do we need fundamentally different architectures that reason about what they do not know? Drop your thoughts in the comments. This is a conversation the clinical AI community needs to have. Thanks for watching. See you next week.